Welcome to Clinical Capsules, your go-to podcast and trusted source for quick, evidence-based insights from TRC Healthcare. For 4 decades, we've been keeping healthcare professionals at the forefront of drug information and medical knowledge. And now, we're bringing these vital clinical updates right to your ears every second and fourth Tuesday, delivering practical, actionable takeaways in bite-sized episodes. Today, Assistant Editor and Clinical Pharmacist Rachel Cole discusses the evolving landscape of first-line medications for type 2 diabetes in an excerpt from our popular Pharmacy Essential Updates webinar series. Let's take a closer look.
So our article says you'll continue to see SGLT2 inhibitors and GLP-1 agonists gain traction as first-line agents for many patients with type 2 diabetes. And as you might imagine, this continues to be a big debate. We're also used to metformin being first-line, but you might see injectable GLP-1 agonists like Ozempic or SGLT2 inhibitors like Farxiga being used first-line for type 2 diabetes in some patients before metformin. So let's look at an example here with our patient Tanya. She's 59 years old and is a longtime patient at your pharmacy. And she has a new prescription for dapagliflozin or Farxiga, 5 milligrams by mouth once daily. For 30 days, no refills. Now, based on what you see in Tanya's patient profile, you know that she has heart failure, and she's taking several medications already for that, including the beta blocker metoprolol succinate and the ACE inhibitor lisinopril. She's also taking a torvastatin for high cholesterol. But as you're talking with her, she tells you that she was recently diagnosed with diabetes, and her doctor thought this would be the best med for her to start for her diabetes. So what do you think about this? Does it make sense for Tanya to start Farxiga first for managing her type 2 diabetes, or do you think she should start with metformin instead? So this is a good example of how this debate will come up in practice, because metformin does continue to be the gold standard first-line med for most patients with type 2 diabetes for several reasons. It's established efficacy and safety. It has a long track record. It's generic and low cost. Metformin also has possible cardiovascular benefits and can be used in patients with impaired kidney function with an eGFR down to 30. But that debate will start to come up more often because our newer classes of diabetes meds, such as SGLT2 inhibitors like dapagliflozin or Farxiga, and empagliflozin Jardiance, or GLP-1 agonists such as semaglutide or Ozempic, or liraglutide or Victoza, we've seen more and more evidence of their cardiovascular or kidney benefits. They're getting a lot of buzz for reasons beyond their effects on lowering blood glucose, and there is robust evidence showing that adding a GLP-1 agonist or SGLT2 inhibitor to metformin improves those cardiorenal outcomes. On top of that, there's more limited data suggesting that those cardiovascular and kidney benefits are even independent of metformin. Now, this is based on less robust evidence looking at subgroups and pooled analyses of cardiovascular studies. But that's why diabetes guidelines recommend these newer med classes first line for some patients with type 2 diabetes, specifically those patients who have compelling indications like cardiovascular disease or chronic kidney disease, regardless of the patient's A1C goal or whether they use metformin. So this is a big change in thinking. The idea that some patients with type 2 diabetes would start out with a med besides metformin, considering all of the benefits we discussed with metformin, and that it's really been the gold standard first-line med for type 2 diabetes for years. But some people are starting to think of the fact that metformin isn't always first. But in reality, these newer meds may not always be practical for patients to use first-line for type 2 diabetes, and metformin isn't going away anytime soon, because there are downsides with the newer meds, including side effects, and especially considering costs. SGLT2 inhibitors and GLP-1 agonists often require prior authorizations or have high copays. So if we look at some of those downsides, for example, SGLT2 inhibitors are linked to volume depletion due to their diuretic effects and possibly hypotension, genital yeast infections, euglycemic DKA, which is a life-threatening complication of diabetes, serious urinary tract infections, and more rarely, Fournier's gangrene, which can be a life-threatening genital infection. And these meds may need to be held during acute illness or hospital stays, along with other potential risks like acute kidney injury. Plus, SGLT2 inhibitors cost about $600 a month without insurance, whereas metformin can cost less than $5 per month. And GLP-1 agonists have their own downsides. They can cause GI effects like nausea or vomiting. They have warnings, such as a rare pancreatitis or gallbladder disease, and pulmonary aspiration following deep sedation. And these can cost about $1,000 a month without insurance. Plus, unlike SGLT2 inhibitors, which are oral meds, most GLP-1 agonists are injectable, which patients usually don't prefer. So, despite that debate, the bottom line here is we shouldn't abandon metformin. It's still practical and it's often needed along with other meds for type 2 diabetes anyway for glucose lowering. So, it's definitely not going away anytime soon. But it's a good reminder that we may see SGLT2 inhibitors or GLP-1 agonists used first line before metformin in some patients. And like with many things in pharmacy practice, this will be an individualized decision based on factors such as cost and the patient's other medical conditions, thinking about those compelling indications that I mentioned before. So when thinking about a patient's comorbidities and whether a med other than metformin makes sense to start first line for diabetes, SGLT2 inhibitors may be considered first line in a patient with type 2 diabetes and heart failure, or chronic kidney disease, or cardiovascular disease such as a prior heart attack or stroke, or possibly in patients with multiple cardiovascular risks, because these meds can reduce the risk of heart failure, hospitalization, or CV death. And remember, our patient Tanya has heart failure. Some SGLT2 inhibitors are approved specifically for some of these other indications, like heart failure or in chronic kidney disease, and they can also treat diabetes. So it may be a bit of a 2-for-1 approach with SGLT2 inhibitors if patients have these conditions and type 2 diabetes. Now, just a quick sidebar about SGLT2 inhibitors in kidney disease. These meds can be started down to an eGFR of 20 for their kidney and cardiovascular benefits and continued until dialysis starts. But if a patient is using these meds for type 2 diabetes, glucose lowering is limited at a lower eGFR, so they may not get as much glucose lowering effect for diabetes as in a patient with better kidney function. Moving on to those considerations of compelling indications for GLP-1 agonists, there are certain GLP-1 agonists that are proven to have benefit in either cardiovascular disease or in chronic kidney disease, specifically injectable dulaglutide, liraglutide, or semaglutide. So you may see these GLP-1 agonists used if a patient has type 2 diabetes along with cardiovascular disease or multiple CV risks, not only for glucose lowering, but to reduce the risk of cardiovascular events. Or you may see one of these GLP-1 agonists used for patients with CKD, especially since Ozempic is now approved in patients with type 2 diabetes and CKD, because these meds may slow the progression of chronic kidney disease. They also don't require dose adjustments for kidney impairment. But GLP-1 agonists do have less data for CKD than SGLT2 inhibitors. And consider a GLP-1 agonist or the GIP GLP-1 agonist tirzepatide for patients with metabolic liver disease or overweight or obesity. So if we come back to Tanya here, we said she has heart failure and was recently diagnosed with diabetes, and she's starting dapagliflozin. So based on what we discussed, what do you think about this prescription now? Well, we said that one of those compelling indications for an SGLT2 inhibitor was heart failure. So Tanya has both heart failure and type 2 diabetes, so the SGLT2 inhibitor can benefit both of those conditions and could be a reason why she would start with dapagliflozin instead of metformin. But I'd want to run this through her insurance. If cost is an issue, metformin might be a better choice. A med can't work if a patient doesn't take it. So it's really going to be an individualized decision weighing pros and cons overall. Again, metformin will still be first line for the vast majority of patients, but we'll likely start seeing more of that debate and that shift occurring over time. So, all of this is a good reminder for technicians to continue to keep medical conditions current in patient profiles so the pharmacist can evaluate which diabetes meds may have the most benefit. Technicians can also stay alert for errors. For example, some of these meds have look-alike, sound-alike generic names. GLP-1 agonists all end in tide, dulaglutide, liraglutide, etc. And SGLT2 inhibitors all end in flozin, dapagliflozin, empagliflozin. Also, double-check dosing. For example, some GLP-1 agonists are injected once weekly, and some others once daily. So diabetes is clearly a huge topic with lots to think about, but our algorithm stepwise treatment of type 2 diabetes is a great resource to think about all the considerations with managing diabetes. I also wanted to encourage you to visit our Diabetes Resource Hub available on our website. This is a collection of articles, clinical resources, and other CEs that are all focused on diabetes. If you're looking for one central location for guidance on helping your patients with diabetes.
We hope you enjoyed and gained practical insights from listening to this presentation. Be sure to follow or subscribe, rate, and review this show on your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. While you're there, check out our other TRC podcasts like Medication Talk and Rumor vs. Truth. Also in the show notes, we've linked directly to a few of the excellent resources mentioned today, available to subscribers of Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights. On those websites, you'll also find a lot more evidence-based, concise, yet comprehensive resources on this and other medication therapy topics. And don't forget to check out our full Pharmacy Essential Updates webinar series for deeper dives into topics that matter to your practice. If you aren't already a subscriber, don't miss out on these resources. Sign up today to stay ahead with trusted insights and tools. We are an industry-leading, non-biased source of information and continuing education. As a listener to our show, you have access to a special 10% discount on a new subscription. Just use the code PODCAST1025 when you check out. And if you're a student, even better, students can access a free version of Pharmacist Letter. We've got links in the show notes that take you directly to the right places to take advantage of these awesome deals. Go check them out. You can find out more about all of our product offerings at trchealthcare.com. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening. Stay sharp, stay current, and we'll catch you next time on Clinical Capsules.